I think we can proceed, Doctor, because that person still trying to connect. Okay.
Assalamualaikum. Okay, I'm talking about respiratory distress in newborn. Kan, betul topik ni?
Tahu.
So, two things lah. Newborn and respiratory distress. Simple kan? You group 2 kan? Block 2 kan? Block 2.
Yes.
So, cause of respiratory distress, banyak from respiratory system, cardiovascular system, central nervous system, musculoskeletal and metabolic. Okay, look through it, respiratory disease, from the airway problems, and then disorder of the chest wall or diaphragms, then malformation of mediastinum and lung parenchyma, Ehrlich syndrome, from airway problem banyak. You can see nasal stenosis, Pierre Robin, vascular rings, colorectasia, laryngeectasia, hemangioma, trachostenosis, congenital diaphragmatic hernia, Ehrlich from interstitial emphysema, and then pneumothorax, pneumomediastinum, and pneumopericardium, pneumothorax, congenital cystic adenomyosis, congenital pulmonary cyst neoplasm, CLE, congenital lobar emphysema, pulmonary arterial pulmonary sequestration, cardiac disease, so many, cardiac amyloid cardiac failure, and then pulmonary parenchyma, so a lot. For TTN, meconium, Hylian membrane disease, pneumonia, congenital alveolar proteinosis, CAP, pulmonary edema, persistent pulmonary hypertension. Neurological banyak, intravascular hemorrhage, meningitis, HIE, pulmonary seizures, and so on, and other miscellaneous. And the other thing they forgot to put here is severe acidotic. Severe acidotic also can cause some patient got tachypnea and respiratory distress. But the most important for you all is to recognize. So recognize, you have to decide, is it mild, moderate, or severe? Mild, sometimes they just got tachypnea and tachycardia only. Saturation still good. Moderate can have subcostal recession, and then nasal flare, and then also they also got tachypnea, tachycardia, and severe. They have all these plus cyanosis, granting, drowsy, and comatose. And you know that is a severe. So when you saw your patient, you have to decide the child is mild, moderate, or severe in respiratory distress. So, but the other signs you can look at, additional signs: poor or not tolerating feeding, inactive, poor perfusion, hemodynamically unstable, stridor, listless, and temperature instability. That's what the other signs you can look at patient with respiratory distress. Treatment, I think you all know already. It's basically ABC, airway, breathing, and circulation. When secure the airway, the most important first thing to do by suction, positioning, using bed and mask or intubation, and look for blood pressure and perfusion. Make sure it's normal, and treatment specific to the causes. And then this is how you do some resuscitation to the newborn who just be. Actually, it's not. Actually, you have to do it on the open care, but right. But this is an example to illustrate how we do the resuscitation. The respiratory system you'll know, starting from the nasal cavity until the diaphragm. From the nasal cavity, pharynx, epiglottitis, larynx, bronchus, trachea, bronchus, right lung, left lung, diaphragms, bronchioles, alveolar sacs, and also the muscles. The muscles of respiratory also we consider as a respiratory system. And then you know that respiratory problem is the commonest, morbidity and mortality, and to a little bit, because you're talking about neonate, so it's good to understand the respiratory system development, which involve embryonic phase, pseudoglandular phase, canalicular phase, alveolar phase, alveolar. Actually, when you deliver, when the baby was delivered, is until this stage, but the alveoli still develop in numbers until the 8 years, and the size and diameter of the respiratory system increase until adulthood. This little bit illustration when the baby or the fetal inside the mother tongue, the mother intrauterine, the face can be divided into embryonic phase, pseudoglandular phase, canalicular phase, and circular phase, alveolar phase. Here is the time. You see start development of airway, bronchioles, bronchi, bronchioles, terminal bronchioles, respiratory, bronchioles, alveolar, and alveolar sac. And the surfactants start to be around, not to detect at the age of 26 weeks intrauterine. Intrauterine. This when you can start detect the surfactants. We're going to talk about the surfactant function a little bit later. So a little bit more detail, you can see from the formation of major airways until the development of the alveoli from here. Start the organogenesis and differentiations. So the most common is that child, the baby that admitted to the unit that admitted to the NICU is respiratory distress syndrome or hyaline membrane disease. It's mainly because surfactant deficiency, which is surfactant is a phospholipid. The function of surfactant is to prevent airway collapse. I mean that you need surfactant. Even all of you now has surfactant inside your lung. So the surfactant prevent the collapse of the not airway alveoli, prevent the collapse of alveoli. So the risk factor is prematurity, mainly. The more premature the baby, the neonate is, the more chance he develop respiratory distress syndrome or hyaline membrane disease. Male sex, prenatal asphyxia, maternal diabetes, antepartum hemorrhage, and cesarean section. And the diagnosis usually clinical and X-ray. X-ray can help you to give the severity of the hyaline membrane disease, and management by respiratory support, fluid, electrolytes, acid-base balance, antenatal steroid, and surfactant replacement. So what the function of surfactant? The surfactant decrease the surface tension of the you see the surface tension of this is the alveoli, scapulary. So in alveoli, you can look here is the interface between the fluid and air, and the surfactant works here. You maintain the integrity of the alveoli by maintaining the surface tensions, prevent the alveoli to collapse. And then it increase the pulmonary compliance and reduce tendency alveoli to collapse. Example better illustrated here, where the surfactant work at the surface interface between the fluid and the air here. So it maintain the integrity of the surface tension, and alveoli didn't collapse. It's produced by the type 2 cells. Type 2 pneumocyte cells produce the surfactant, and it works here. So this is the lung. The child, the baby who has severe RDS, you can see it's very solid lung, liver-like we call it. Lung solid. We call the alveoli collapse totally. You can see very solid lung. And this X-ray, this severe type of hyaline membrane disease. You can see very severe. This is type 3, very severe. You can see a bronchogram only, but it show you almost all the alveoli collapse. So the lung becomes solid. That's why it looks like mainly like all just white consolidation. That's all. You see the trachea, the bronchus, and the bronchioles. That's all. A bronchogram. Treatment-wise, many of these cases need ventilator, mechanical ventilator, but some do not, but some those very severe one, they need the mechanical ventilator. And but the main treatment is replacement. So there is one of the artificial surfactant. You give it to replacement. You buy the time before the body, the lung itself produce their own surfactant. The other one is congenital pneumonia. Congenital pneumonia, by definition, you already know that it's lung infection due inside intrauterine or congenital, intrauterine, or just baby come out from the mother womb. So mainly it's group B streptococcus, but other organisms, Listeria, Klebsiella also can cause. The risk factor is maternal fever, infection, maternal having UTI, chorioamnionitis, inflammation of the amnion fluids, premature rupture of membrane, prematurity itself, colonization of the tract or delivery tract by group B straps. The treatment is mainly antibiotics. You support the baby, at the same time you give the treatment. The transmission of the bacteria can be hematogenous, ascending. It means that from the lower part of the genital, the mother genital part, and go up, ascending into the intrauterine, or aspiration. I mean that when the baby come out in the canal, delivery canal, they aspirate the fluid, or and at the same time the germ, the bacteria, if there is a colonization of the birth canal. Sign and symptom: tachypnea, retractions, grunting during exhaling, nasal flaring, increased mucus and other fluid substance in the airway, which can be whitish, yellow, greens, hemorrhagic in color, unstable body temperature, poor feeding, abdominal distension, jaundice at birth, glucose intolerance, hypoperfusion, oliguria, and cyanosis. All the signs and symptoms of patient is called sepsis, with a lung infection, infected lung. So this is chorioamnionitis. And then this is the X-ray. You see the X-ray a bit different, is it? That one is very whitish, with small medullary, small node, whitish, small nodule, like grain in the sand, grain. This one is a bit superfluous. This is consolidation. You see the consolidation, I mean that the aruli is inside the aruli is a pus and pussy things, and fluids and consolidation. Bronchopneumonia is bronchopneumonia. The other one is the collapse aruli become consolidate. So big difference. You can see here. And then treatment is, as I said earlier, you support the child, ABC and so on, fluid, but antibiotic is the key treatment. The other is transient tachypnea to neonatal, TTN. Quite significant amount, 1 to 2%. Usually larger preterms, mainly occur in term baby. Occasionally can occur premature, but mainly in large preterm and term. The pathophysiology very simple. You know, intrauterine, your lung content mainly is a fluid. So in order to survive, your fluid inside the lung must be clear. The lung, so the air can be in the lung, instead into the lung, the air is the fluid. But at certain time, because physiologically, when a child cry and there is positive pressure, result in the fluid can come out, and then many of them also been absorbed by the lung, so result in the lung is clear, so the air can be placed. But some patient, some maybe it takes time to do that. It doesn't occur immediately. So they are residual, the fluid left over inside the lung, and this fluid cause morbidity. Then the morbidity is the respiratory distress. So the future is the same. Child is tachypneic, desaturation, subcostal recession, intercostal recession, almost all the sign of respiratory distress, except they don't have the sign of sepsis. But usually rarely persists more than 40 hours. It will resolve after 40 hours. And it mainly, one of the risk factor is a cesarean section. Because cesarean section, you take out the baby immediately. Unlike in the birth canal, SVD, the baby come out at the first phase 2, and during the baby come out, so the fluid in the lungs start to come out, clear. So the X-ray, you can see the X-ray, you can see the line here. It's a fluid in the fissure. It tells you that the lung is wet. Sure. Jadi meconium expression syndrome. Meconium is baby, for the something stress the baby inside the intrauterine, the baby pass motion. So mainly the meconium, they pass meconium out. Meconium out if baby is stressed intrauterine. The meconium consists of fetal GIT tract secretion, epithelial cell and hair. And the problem with meconium, you can look here, very sticky. Very sticky, pneumonia, and it will cause obstruction. One, second, it is also quite corrosive. It will cause pneumonitis. The risk factor mostly postterm or baby asphyxiated. And then the features, the liquor, the color of liquor is not clear. The meconium in the liquor, meconium in the stain, and also patient develop respiratory distress at the same time. I mean the sign of tachypneic recession and so on. And the treatment mainly is prevention, good antenatal care, and during delivery, you try to suck out as much meconium as possible. So to prevent the meconium goes into the lung. You can see the meconium, very sticky. Can you imagine this thing inside the baby trachea or in the baby lung? And then there is all pathophysiology. So it's very complex pathophysiology. So result in the airway obstructions, and then they destroy the surfactants, and then it causes inflammations, cause mediator to come out and affect the lung resistance, mechanic of the lungs, and toxicity of the meconium. So they call it meconium expression syndrome. When you saw the patient, it's all respiratory distress syndrome like patient. No, tachypneic, cyanosis, hypoxic, same, but the pathology is different. See the X-ray? The X-ray is so hyperinflated of the chest, of the lung, which told you that there is an obstruction, and then there are soft consolidation here, very softy. We told you that there is a meconium inside the lung. This is meconium. The other one, there's pneumothorax, pleural effusions, pulmonary hemorrhage, congenital anomalies such as hypoplasia of the lung, sequestrations, congenital diaphragmatic hernia. Anybody know this? Anybody can figure out? Siapa boleh teka? What is this?
Is that a chest without lung?
Yeah.
Medial part?
This is chest without lung. Okay, then what anything else you notice?
Loss of lung.
Bowel
Lung parenchyma.
in the lung.
Bowel in the lung.
There's bowel in the
Lung space.
the stomach. Bowel. The lung tissue is hypoplastic, very small. We'll call this.
Diaphragmatic hernia.
Yes, this is diaphragmatic hernia. Borderlet. Borderlet. Most common is diaphragmatic hernia. See, they're on the X-ray. On the, you see the absence of pleural peritoneal membranes here, result in the indentation of the, or the GIT tract tissue went into the thorax cavity. Left lungs is compressed, and the X-ray, you can show the X-ray here. You can see the gas bowel, is it? We show that inside here is the what inside here?
Intestine.
Yeah, the intestines. Intestines here. It's the lungs here. We compress. It is we call congenital diaphragmatic hernia. It's another one, smaller in size. This one, what do you notice? This is the chest cavity, is it? Which one is bigger, left or right?
Left.
Left.
Left, is it? Very big here. And this is the, seem to be, the mediastinum be pushed to the right side. And this is lung tissue. What is this?
Pneumothorax.
What is this?
Air.
Air.
It's air. What we call this?
Pneumothorax.
Pneumothorax.
Tension pneumothorax.
Yeah, you can also call tension pneumothorax if you want to. Is this anything else you notice here? First, you notice there is a mediastinum is rotated film, but the mediastinum will push to the left side, is it? But there is something here, is it? Seem to be like dark color, is it? So what is this? It's not as dark as this one, is it? But still quite dark color, is it? When they do the CT scan, they notice there is still some tissue here, lung tissue, but the lot of air inside the tissue there. What we call that? Emphysema. But this is just been born. So the development of emphysema is inside the intrauterine, not due by smoking, like in adult. So we call it congenital, and it's occurred in one lobe, lobar emphysema here. See, and they compress the bronchus. They compress the bronchus, result in this place, this side of the lung cannot function properly. They compress the lung also. See different the parenchyma here and here. This one, anybody notice anything? The chest X-ray. The chest X-ray, what do you notice? There is
the left lung
seems to be there
more
is
to the upper and middle.
homogeneous consolidation here, is it? Margin is lower, very nice margin. Yeah. So it's like a cyst, is it? It's a bronchogenic cyst. What happened? Why they cause respiratory distress? You see this the trachea. It compress the trachea and it also compress the left bronchus. So the result is very massive, big cyst like this. You will compress the trachea and then the bronchus and result in respiratory distress. This one, child is ventilated. By right, how big the size of the lung going to be? It's supposed to be until here, is it? Tapi it's very small, It doesn't. small lung, very small lung, volume of the lung. What we call that? But the lung is still there. This is the hypoplasia of the lung. This is the very small lung. Quite healthy like lung. You can see the first one that the RDS just now, the lung is very solid, is it? Solid, is it? This one the lung. You pernah makan lung lembu tak? Tak pernah. Tak pernah makan. Tapi the lung is small, is it? So they have hypoplastic lung. This is another airway abnormality. They are quite uncommon, quite rare airway abnormality, such as stenosis, tracheal stenosis, or bronchial stenosis, or laryngotracheomalacia. I mean that there is the lung is so soft it collapses, melasic. When you take a breath, lung just collapse, the airway just collapse. This is stenosis, this airway abnormality, this airway. And then tracheoesophageal fistula. There are many types of fistula. Tracheoesophageal fistula. Like this one. What happened is this one is normal, and this one is the fistula. Bila budak tu makan, eat, then it will aspirate the lung. Here also makan, aspirate to the lung. And here breathing can cause air into the lung and also the fluid into the lung, food into the lung. Here milk, just cough up, go back into the lung. So this is fragile tracheoesophageal fistula. The child can come with aspiration syndrome, with tachypnea and respiratory distress. The other causes are cardiac. I'm not going to talk a lot about cardiac, but you know cardiac, congenital heart disease, cardiac failure, cardiomyopathy, or many of them mainly they cause the heart failure. When they cause the heart failure, you know the sign and symptom of heart failure, the lung become very wet, is it? And the child start to become breathless, and you notice the child become tachypneic, tachycardia, and then respiratory subcostal recession. It escalated a lot of capitations because of pulmonary edema, and then there is the child will be in respiratory distress. Cardiac cause also important cause of the respiratory disorder in the newborn. The other one, which is not very common, muscular problem, like spinal muscular atrophy. You see, you need muscle in order to bring the air into the lung. So if the muscle dysfunction, for whatever reason, like SMA, degenerative disease, failure of the motor system, result the failure of the conduct, the message, the failure of the nerve conduction. I mean you need, because we are breathing, muscle to contract, not to contract, you need the nerve to send electrical wave. So to tell the muscle to contract or not to contract. And then because the muscle when contract, you inspire. When you doing expiratory, then inspiratory, is it? When the inspire, the muscle of respiratory contract, you inspire, the muscle relax, you expire. So this, when the failure of the nerve, the nerve, the central nervous system and the peripheral nerve result in the muscle become paralysis. This very little air can in and out, because you're unable to generate the mechanics of the difference in term or in the pressure, intrathoracic, extrathoracic pressure. And the problems can be in the brain, that say burst asphyxia or hematoma, or the problem can be in the spinal cord here, or can be in the motor center, anterior horns like SMA, or in the nerve conduction, or can be in the muscle itself. Like in example of muscles in myasthenia gravis, the muscle itself, or certain muscular dystrophy, the muscle is abnormal, and then this result in the muscle cannot move, the mechanics, and then if you have the lung, you have the heart, you have the lung, if the muscle doesn't work, the air cannot move in and out. But the sign a bit different, because the muscles is weak. They don't have much tachypnea. Unlike, because the muscle is weak, the muscle at the nervation is abnormal. So they have, you can see the effort. The effort is there, but tachypnea doesn't look so much, because they cannot generate enough power, energy to breathing effort. So you can see the movement, very little, not much movement, sometimes no movement at all. A bit different from those with the respiratory problem and cardiac problem. When you look at the chart, floppy, like doesn't move at all. Sometimes there's no movement of the limb at all, to tell you that the muscle didn't work. So the clinical sign is a bit different compared from those with respiratory and the cardiac problem. So the treatment is the same. We go back again yang see the causes, you can see neurological causes, so many neurological causes, and muscular disease, myasthenia gravis, polio is very rare. Usually don't occur in unit. We're talking about the unit, so you can see cardiac problem also, TGA, and then abstain. This all the other causes. Sanity is mainly is cardiac failure, cause respiratory distress. So all of this, the treatment is still, basic treatment is not much difference. The basic difference, not much. The basic treatment is not much difference. Basically, you have to always in your line ABC first. You have to see ABC. Assess immediate management is ABC. Airway, breathing, circulations. You give the airway, make sure the airway is clear. You make sure that you support the airway. If the child can breathe, if airway is all right, you look to the breathing effort. If breathing effort is all right, then you look for the circulations. Sometimes patient need just oxygen. Sometimes patient need CPAP, sometimes patient need proper intubation and ventilation, depend. Then only when you give the ventilation support, then you treat the main cause, whatever the cause is. Is it Saventa, is it antibiotics, or sometimes you can, if patient need operation, like just deformatic hernia and other surgical cause, as I showed earlier, CLE, all these need operations, treatment. Okay, any questions?
Doctor, I would like to ask, is there any duration, bukan half-life, total duration for the surfactant remain in the body, especially the surfactant that we give from external sources?
6 hours to 12 hours. It depends. Normally can go until 12 hours, even 24 hours to 12 hours, because it will be circulated, absorbed, but over the time it will be metabolized. But let's say it's meconium, certain, because there are toxic inside the lung, the surfactant can be shorter, the life.
So basically, for the baby who needs surfactant from external sources, have to top up with surfactant every day.
It depends. You wait until the body when the lung is opened up, and then the body produce their own surfactant, then you don't need to, because over the time your body will the body will produce its own surfactant over the time. It depends. One is how mature the child is. The more mature the child, the faster the body going to develop the produce their own surfactant. And then it also depends the nutrition of the child and baby, the neonate, the baby, and also depend of if the lung is, how bad the lung is. Some patients, some because there is surfactant deficiency, it means that it can be 0 until 50%, 70% deficiency. That doesn't mean that they can have complete deficiency. Some baby need only 1 dose, 2 dose. Some baby need for quite a few, more than 1 or 2 or 3 doses. It depends case to case basis. But eventually the body will produce its own surfactant. Any other questions?
How do you know how many doses should give to a baby? Is it just by clinical examination?
By clinical, there are standard protocol, but at the end of the day, we decide clinical. Don't worry so much about that.
Okay.
When you come to the NSU, you will learn how to do it. Okay.
All right. Thank you, Doctor.
Any other questions?
I want to ask. I read about Silverman-Anderson scoring system, or to assess Silverman-Anderson scoring system to assess the degree of the respiratory distress in neonate. Do we use this scoring in our practice?
Depend. I don't use. Okay.
Huh?
I didn't use. Some people use, some people don't use. It's up to you. You think it's useful, you use. Some people think there are other scoring, and then some people say no need to do. We don't need that because we can assess our own.
Okay, thank you, Doctor.
It's your choice. It's not a must. It's not a must. You decide if you want to use, you don't want to use. And there are other scoring. Anything else?
Doctor, under the transient tachypnea neonatal, the risk factor large preterm and term tu, what is the meaning of large preterm?
The big baby lah.
Oh, the size, okay.
Preterm tapi probably last preterm mean that some baby dia preterm tapi dia still 2.5 kilo, 2.6 kilo. Term ni cukup bulan lah.
Alright, thank you, Doctor.
Anything else? Okay. You have to look this as introduction, because first of all, you're not going to go NSU, or you can go to NSU as a visitor, you're not going to be there as in the ward, mainly for introduction. And second thing is to make you recognize the disease and to know the disease. Because you mainly you go practice and as you when a houseman you do some basic things, then and then more details when you manage this baby when is in ICU. But usually in the exam we don't ask you much about this. In the exam you don't come out because how to be unethical to put this kind of baby for the exam, but you have to know about it. So people talk to you, what is hyaline membrane disease or RDS? You know what is this? It's due because of deficiency in surfactant and the presentation the child can be respiratory distress, this treatment is surfactant. Treatment is we support the baby with respiratory support and we give a surfactants. So you know what is it? What TTN? What's TTN? TTN is due because of the fluid in the lung isn't clear properly, result in residual of the fluid, and this residual fluid is large enough, result in the respiratory distress. Usually it's a term baby and a cesarean baby, and then most of the time after 48 hours they resolve because of the fluid in the lung, the extra one will be absorbed by the lung. So you know about it. That's the main thing. Okay. 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 Finish now. Berapa ramai you all ni?
26.
26.
26. Tak nampak muka-muka ni. Kuzandra. Siapa Kuzandra ni? Kuzandra. Siapa Kuzandra?
Saya yang tanya soalan pasal surfactant tadi.
Nak you nama Kuzandra ke Sabila Soleha? Apa nama isu apa? Bilang lah.
Nama saya ke? Kizandra Maisara.
Mana dia? Angkat tangan.
Angkat tangan. Angkat tangan. Angkat tangan Rashan.
Mana you? Tak nampak?
Sekejap, kalau saya buka nanti dia punya, saya akan log out sebab internet tak kuat.
Oh, sian. Internet tak kuat dia. Kena power. Internet lemah. Internet tak kuat. Kena kuat.
Sebab hujan.
Dia bahasa Malaysia apa? Internet tak kuat ke internet apa? Dalam bahasa Malaysia, internet apa? BM. Bahasa Malaysia. Weak.
Lemah.
Strong. Bahasa Inggeris apa? Internet apa?
Poor connection.
Poor connection. Dalam bahasa Malaysia?
Internet miskin.
Ada tahu kuat ni, you know, kuat tak kuat atau macam mana? It's a better language for internet connection tak bagus apa? Internet lemah. Mesti kita
Saluran lebar tidak.
yang kita bahasa Malaysia kita tak expand kan vocabulary kan. Vocab. Kuat
Capaian internet rendah.
Oh, banyak sangat bahasanya budak you.
Internet.
Tak suka benda panjang sangat.
Internet perlahan.
Okey, tak apa. Okey, finish Okey. You dekat mana semua ni? Siapa dekat siapa duduk dekat ni? Dekat Sabah. Ada?
Saya.
Amiza.
Siapa? Siapa Sabah?
Doktor.
Yelah siapa saya tu?
Hamiza. Saya.
Ya, oh.
Hamiza.
Macam mana betul itu kat situ lah nanti rasa Sabah tak ada keluar lagi. Sabah, Selangor siapa Selangor?
Saya lagi.
Selangor. Apa jadi dengan Selangor?
Alah, semua salah ahli politik. Tak ada. Lupakan.
Apa, sini saya orang beritahu senyap je, masalah orang politik pun. Dia orang punya pasal lah kita jadi macam ni. Apa? Tapi hilang beasiswa. You tell the truth, hilang beasiswa.
Saya self-sponsored.
Sponsor apa lagi? You tak takut. Apa you takut pula? You don't own anything. You pay on your own. The rest if your parent tax. Your parent bayar tax tak? Tak bayar. Income tax, bayar income tax kan?
Bayar.
Itu apa you risau? We are income tax payer. Dia orang semua bising-bising kat parlimen tu kita tax kita. Okay. Tak ada lagi teaching you, ada teaching tak ada kan? Next week ya. Tak tahulah next week macam mana clinical. Tak apalah we think about it. Okay.